You only have to look at the grim milestones that we're now seeing globally, and really, we're not even calling it a second wave, but just the continuation of infection surging across the US to know that this is a virus that doesn't react well when people become complacent. And yet here in Australia, nobody wears masks. You go out on the weekend, there's very little social distancing going on. Is there too much complacency amongst the public and perhaps policymakers?
Good morning. Thank you for having me. Look, I think that one of the very big problems is while our authorities have done very well, of course, like most countries, they have had some errors in their approaches. But one of the errors that I find difficult to understand is instead of being proactive in their approach, they're rather reactive. So at the moment, they're finally starting to do some testing in the hotspot areas, and they're contemplating the idea of ring fencing, what we would be epidemiologists would call ring fencing. The majority usually call it lockdown, but ring fencing hotspots. So they're certainly testing in hotspots. They're starting to test in hotel quarantine populations, but of course, hotels are not purpose-built for COVID-19, and so we really need to start thinking about a purpose-built facility. But the lack of advice on masks is difficult to comprehend. I was on the committee of WHO that revised the mask guidelines. We looked at brand new evidence of the efficacy of good cloth masks as opposed to the old-fashioned ones that were a bit like a hanky. And there is no understandable reason why they're not explaining to people who live in those hotspots to wear a mask when they go out and when they can't keep social distancing in public transport.
To be fair, though, I think a lot of people attribute the inconsistent advice from the WHO. I know you say the advice has subsequently been revised, but it had been previously that unless you're a medical professional, you don't need to wear a mask. So how much does that sort of complicate things, particularly in the broader context of how do you give advice about, you know, a pandemic and a virus that we're learning new things about every day?
Yes, look, that's a reasonable criticism, but what I don't think WHO has been very good at is marketing the idea that it is a repository of evidence. If we can't, as a group, we can't find evidence, we then use best practice and professional agreement and laboratory testing, not necessarily testing from the community. So we did that, and initially we didn't want people to wear masks that were medical-grade masks because there still is a supply chain problem for frontline workers. But I guess it could have been sold better with the idea that we will change along with countries, and their authorities will change tact and change advice, and the public need to be resilient as we learn new evidence. And that's what we were doing, learning best practice evidence that masks were important. Now in America, the CDC had already supported the idea of masks, particularly in your high-density cities like New York City. So each country can make their own decision, but mostly they look towards WHO. And yeah, I take the criticism, but we need to be resilient and start changing. And the Australian authorities could change to say, when you hop on an aeroplane, please wear a mask, because at the moment there's no requirement for masks in those crowded conditions.
You mentioned the CDC. We continue to see more guidance coming from the organization on how to safely reopen. The only problem is that for cities like New York City, a lot of those guidelines don't really have an impact. They want more people to avoid public transportation. It's not really a reality in New York City, given the reality not only of New York, but also very crowded emerging market economies. Is quarantine the only and best solution? And what's the next best when you continue to see this resurgence of virus cases with this reopening?
Yes. Look, in outbreak management, it's not just one infection prevention strategy. It's a bundle. Americans develop this idea of bundling infection prevention strategies within hospitals, and that's exactly what happens for outbreak management. So it's keeping physical distancing, it's getting tested, it's staying away when you're unwell, and it's wearing a mask. So it's all of those, and then it's home isolation for 14 days. Now, in some countries, they're finding that perhaps roving or rolling 14-day on, 14-day off may help to break the transmission. And certainly it might be the case for some parts of America and certainly India, where at the moment in New Delhi, the cases are skyrocketing.
When it comes to some of the advice that we got from WHO, we had also some conflicting reports on whether or not the spread was occurring by asymptomatic carriers. Do we have any more idea on where this lies and how dangerous this spreading is when there are no symptoms that go along with the disease? And how then do you try to really rein in the virus in places like the United States, where it's clearly resurging and the cases now are in the millions?
So 100% of cases will be, we think, infectious at least 2 days before they start getting symptoms. And cases include those pre-symptomatic, so before people start to get their symptoms, and they will get it, and a proportion who are asymptomatic and will remain asymptomatic until they finish being infectious. Now, we think there's a lot of studies that have been put together using meta-analysis that include studies that didn't follow up asymptomatic patients to see if they eventually became symptomatic. So when I was in a group that looked at only those studies that followed up asymptomatic cases for at least 7 days up to 21 days, and we found somewhere between 12 to 18% of cases will remain asymptomatic for at least 7 to 21 days. And that is problematic, because it suggests that there will be a group that are kind of silent cases, but we still don't know if they are important spreaders. We find them in clusters, they get tested early, and we assume that they are infectious, but we don't know how important they are at driving this disease. Certainly, the pre-symptomatic cases find that they are infectious 2 days before, and they do drive this outbreak. But those silent ones are difficult, and that's why testing is so important, to flush them out.
We spoke with Professor William Hazelstein just a couple of weeks ago, and he had some pretty stark kind of, reality checks, if you will, saying that herd immunity is a fantasy, that an effective vaccine, he thinks, is essentially a fantasy. He doesn't think we'll actually get one, and if we get one, it may not be really that effective. What would you say to people, including policymakers, that are kind of banking on the hope that we'll either get immunity of some long-lasting factor or a vaccine that'll save the day?
Yeah, look, I think he's right on several fronts. If we have a look at the immunity after SARS 2003, your peak immunity was at 4 to 6 months only, and then it started to decline, particularly by 16 months. So we don't know at this stage if you've had one COVID-19 illness and you get a second one, if you're going to actually get sicker than you did the first time. So there's so many things we don't know, and this is why we don't want people to get sick. And there are about 194 candidates for a vaccine. 2 are being currently started to be trialled in phase 3 for safety and dosing in Brazil. And that'll be about 9,000 volunteers. And he's right in that this may not work. They failed, the vaccinologists failed to get a good vaccine for SARS and for MERS and Ebola. And this disease may be as difficult to find a vaccine. And this is why we need all global citizens to do their level best in trying to keep their citizens from getting sick and from spreading it. And masks, social distancing, getting testing, and staying away from each other in those high seroprevalence areas is really important.